there's a lot of buzz about pediatric myopia and childhood myopia progression, the myopia management. Why is it so? Because, we have seen that the myopia is showing a rising trend, not only globally, but also in India. Globally, if you see, it's quite alarming in Southeast Asian countries, almost 80 to 90% prevalence in China, Taiwan, Korea. And in India, there is near doubling of the prevalence that we have noted in the last 1 decade. So we cannot ignore the fact that myopia is becoming a public health crisis. And so this instruction course and discussion about its management, where we will not only try to, give you an evidence-based update about the myopia, but also try and discuss that how you can apply this knowledge based on the scientific evidence in your clinical practice. So moving from preaching to practice, and of course, then we will have certain unanswered questions, certain the dilemmas that still exist in its management that we can probably discuss rather than answer amongst the audiences and our lovely speakers. And so I think we can quickly move on to the first talk of the session. That's so we have a well-known pediatric ophthalmologist from all over the country here. So first I would like to invite Dr. Siddharth for his talk on etiopathogenesis and theories of myopia progression. In fact, sir has recently published a paper in IGO where he has supported the safety and efficacy and the acceptability of 0.01% atropine in childhood myopia. Right.
Thank you, Rebecca, and warm welcome to all of you to this IC. And so my topic is on the genesis of myopia progression, because we need to understand how myopia progresses in order to understand the strategies that can be used to prevent myopia progression. So these days you come across a lot of new modalities in the prevention of myopia progression. You have to know why it is progressing in order to know at which point do these modalities work. So there's always been an argument whether it's the inherent nature of a child that leads to myopia or whether it is his environment that leads to myopia. So it's always nature versus nurture. Nature is what the genes that you are born with, and nurture is the surroundings that you live in. So you would have seen that in developed countries and where in developed economies where people are getting more and more educated and people are moving towards the cities, in those areas the incidence and progression of myopia is more. So there has to be something to do with the environment in which a child is brought up also, that is also contributing. Now genetic definitely has a role to play, and there is no single gene which can be blamed for myopia progression. In fact, there are several genes, almost 100 genes, which are shown in children who are progressing with myopia. If your parent has a myopia, if one parent has a myopia, then 10% risk of myopia in the child, and if both parents have, then the risk is up to around 40%. There are more than 100 candidate genes for myopia progression, but these are running in families. We are more worried about why school myopia happens, or why a normal person with no family history becomes myopic. So for that you need to understand how the eyeball grows. So when a child is born, he is not having perfect eyesight. So he's not 6/6, he's not emetrope. He can range from very high myope to very high hyperope. When they are born and then they open their eyes are getting stimulus from all around, and that is pushing their eyes towards emetropia. This process is called emetropization. So here in this graph you can see on the left side you see the refractive error spread across the spectrum in a newborn, and as the child becomes 6 years old, they tend to bunch around emetropia. So how does this process happen? In order to understand that, people did an experiment in animals, and several animals, we owe the signs to these animals, which can be chicks, shrews and monkeys, wherein they use two strategies. One is form deprivation myopia and one is lens induced myopia. Form deprivation myopia is where you shut the eye of the animal after they are born and see how the eyeball grows without any external stimulus. And lens induced myopia is where you either put a negative lens or a positive lens in front of the eye and see how the eyeball responds. So the first concept is hyperopic defocus. You must be hearing about this a lot since the myopia control lenses have come. What is hyperopic defocus? If you stimulate these animal eyes with a positive lens, then you are creating a hyperopic defocus. And a negative lens, a minus lens, then you are creating a hyperopic defocus, because the rays will be focused behind the retina, and that will lead to elongation of the eyeball in order to accommodate those rays. So if suppose this is the back side of the retina, and the rays, you are, by using a concave lens, you are putting the rays behind the retina, then the retina is going to try and seek the image, and it will cause elongation of the eyeball. So when the rays are focused behind the retina, it is a hyperopia, no? So when you have a hyperopic defocus, the elongation will happen and the axial length will increase. Now this effect is also seen if you cut the optic nerve of the animal. Suppose you cut the optic nerve of the animal and still stimulate it with a concave lens, still the eyeball grows. So that means it is not the visual pathway which is dictating that, it is something which is happening very locally. The same thing happens if you put a myopic defocus. So if you use a plus lens in order to focus the rays in front of the retina, then the eyeball elongation stops actually. So this has also been demonstrated. And recovery. So once you remove that stimulus in these infant animals, the eyeball again tends to move towards the image. So that means it tries to stop the elongation of the eyeball. So recovery is possible. So here the stimulus causes the increase, and if you remove the stimulus, it arrests the increase also. So this shows that by stimulating the retina in a particular way, you can increase or decrease the myopia. Okay. Now, if the lens is optically corrected, so suppose if you induced myopia in an animal by putting a concave lens, and then later on you corrected the myopia, then this myopia will stay. It will not go away because now the image is formed on the retina, and so there is no stimulus for it to get corrected. So in these infant eyes, when you remove the stimulus, again there will be recovery. So this is the arc which has been proposed. So there is a defocus on the retina which leads to a retinal response. So the retina is not getting a clear image, so it sends signal to the sclera in order to grow. So when the sclera grows, the retina goes back with it, and then the image is focused on the retina. Same thing happens when you are trying to do some near activity and you are not able to focus because of an accommodation problem. That will also cause the eyeball to elongate. That's why you see the studious people in the class will get glasses, because they are doing a lot of near activity. Near activity requires accommodation. Now, if there is a difference between the amount of accommodation required and the accommodation that he can do, that will lead to elongation of the eyeball in order to accommodate that image. So these are the two ways in which the eyeball can grow. So the question comes then, suppose somebody has got myopia and you have given him a minus lens and he is corrected now. So there is no stimulus for the eyeball to grow, right? He is corrected. So neither should it become more myopic, nor should it become less myopic. But you would have seen that everybody starts with 0.5, 0.75, and then you give those glasses. Next year they require more. So why does this happen? You've already corrected and the stimulus is not there. So to see what happens, this Earl Smith did experiments in the late 90s, and what he did, he ablated the fovea of the monkey, okay, and then stimulated the periphery with a concave lens. And he saw that in spite of the fovea not being there, so now you don't have the optic nerve, you don't have the fovea, still the eyeball elongates. Okay, so when you are correcting the eye with minus lenses, probably it's only the fovea which is getting corrected, but in the periphery it is still hyperopic defocus, so that is causing the elongation. This was again proven by stimulating only a part or a section of the retina. So if you put a hyperopic lens just to stimulate a small portion of the retina, then only that part of the sclera bulges out. So as you can see in this MRI image, where only a part of the retina is stimulated with a hyperopic lens, only that part of the sclera is bulging. Okay, so this is a very local communication that happens between the retina and the sclera. So where the image is not clear, the sclera will tell the retina will tell the sclera to grow, and that way the eyeball will elongate. So what happens in spectacle wear, where you are using your normal spectacles, you are putting a lens which is focusing the image on the sclera, but it may not be focused in the periphery. So it's the sum total of defocus. So at one point there is no defocus, remaining part there is hyperopic defocus. So the sum total is hyperopic defocus, that is enough to cause the elongation of the eyeball. So somebody might say, then don't correct myopia, let it little bit of myopia, leave it. Like olden times people used to leave around 0.5 myopia, because then all the time there will be myopic defocus and you require a hyperopic defocus for the eyeball to grow. So if you leave the child myopic little bit, then it will not grow, logically correct. But what happens even if you leave him 0.5 under corrected, still in the periphery, because of the oblate shape of the retina, it is hyperopic only. And you can't leave him -1 or -1.5 undercorrected. Probably that would be a good strategy, but then he won't be able to see properly. So the entire purpose is defeated. So that's why it doesn't work. And in other, so you must have heard that progressive bifocals work. I think somebody will cover it later. They also help by stimulating the periphery of the retina. So now this is what happens with the general stimulus which is coming from infinite. So now what happens when you are doing near work? So you would have seen that near work, education, affluence and urbanization all contribute to the progression of myopia. So what is that happens in near work that is not there in distance work? So it is accommodation. So you are accommodating when you are doing near work. So maybe there is some problem with the accommodation. That is where the theory of lag of accommodation comes. So suppose you want to see at a distance of 30 centimeters, 33 centimeters. Now you require an accommodation of +3, suppose. And if your eye is going to provide only +2 accommodation, that one diopter is the accommodation lag. Then you might say, then why is he still able to focus? There is an accommodation lag, then how is still focusing? That is because of depth of focus. So the moment you see near, there is pupil constriction. When the pupil is constricted, the depth of focus increases. So in spite of the image not being in clear focus, you are able to see or read. So accommodation lag is uh, is is also thought to be one of the causes of progression of myopia, where the amount of accommodation that is supplied by the eye is not enough, not equal to the demand that is laid on the eye. That's why they say in bright light you should read. Why you should read in bright light? Because when you are reading in bright light, your pupil constricts. When your pupil constricts, your depth of focus increases. So when your depth of focus increases, you have to accommodate less. So when you have to accommodate less, there is less stimulus for myopia. That's why reading in dim light is not suggested. Uh, I think the remaining topics will be covered by them. Thank you very much.
Thank you, sir. I think you have beautifully covered, the etiopathogenesis, which is quite the most controversial part in myopia, beautifully and in detail. So, because based on this etiopathogenesis and the risk factors, you will then devise your management options. So, now directly coming on to the management options in myopia. So, the most common and the most accepted intervention that we know is the pharmacological therapy. So, I would like to invite now Dr. Swati Fulgele to give her talk on pharmacological interventions in myopia. Dr. Swati is the additional professor at RP Center, AIMS, and she's a backbone of our pediatric ophthalmology services.
Good morning, everyone. It's nice to see you all here, and I thank Dr. Rebecca for giving me this opportunity to be part of her instruction course. Today's instruction course is very, very important kind of instruction course because myopia, as we know, is increasing, day by day. It's a huge challenge that we have to face maybe in coming times. So the prevalence is increasing worldwide, not just Chinese population or the South Asian population, which we used to believe earlier are more prone to myopia. No, it has been seen that there's the increased prevalence equally in Indian population as well, and probably some amount of increased incidence or prevalence in Western population as well. So it's worldwide, it's increasing. Of course, it's increasing at faster rate in South Asian region, but that's not stable, or it's not increasing in other parts of the world. There are multiple management options. The research is going on. A lot of people are working on a lot of things. And as we know more about the pathogenesis, which my previous co-instructor spoke about, we will know that how things can be changed. So the options are basically optical, pharmacological, lifestyle, and environmental modifications. So the last one is preventive, and as we always say that prevention is better than cure. So it's always better to expose children to that kind of lifestyle, outdoor activities, and try to decrease their near work as much as possible. Especially the work on phone, tablets, gadgets should be avoided as much as possible. Optical, I think someone else will be talking about, is probably the recent development in the management of myopia, but it's still not so clinically feasible because of the very high cost. It may or may not be effective, is a different matter, but definitely it's not cost effective. So pharmacological management is what is clinically routinely most practiced way of preventing myopia or preventing the progression of myopia. It doesn't prevent the myopia, it simply decreases the progression. It's the most accepted kind of treatment. So there are multiple, sites where these pharmacological agents can act depending on their receptors. So you have growth factors, you have antimuscarinic agents, growth inhibitors, which act at sclera and choroid. So most of these agents act at the level of sclera, retina, choroid, so that the synthesis there is less growth of these tissues, and there is less elongation of axial length. Prostaglandins, dopamine analogs, all have been tried and are still under research but not clinically available. So, atropine is the most accepted, most widely used pharmacological agent for the prevention of progression of myopia. As we all know, it's a non selective muscarinic receptor antagonist, and it's the only drug that is available for clinical use. It's also the most extensively studied drug, and it's like, the as previous speaker spoke about, that the major problem with myopia or the major etiopathology is accommodation. So this is where the atropine comes into picture. It's a logical thing that, something that will relax the accommodation will also decrease the axial length elongation. So, atropine in management of myopia, the most important study and most of our knowledge, our understanding of use of atropine in myopia progression comes from the landmark studies. The number one study is ATOM-1. It was a study where one eye was given atropine and other eye was used as control. And in ATOM-1, they had used the higher concentration of atropine, which was 1%. The study showed that there definitely was decreased myopia progression at the end of 2 years, while the fellow eyes grew at an average of 0.38 mm, which is very high in terms of axial length. There was also significant decrease in axial length in first year, but however, for the third year, when the atropine was stopped, they found that there was rebound increase in the study eye as compared to the fellow eye. So there was some major concerns about this study because, one, it could be a little ethical issue there that you are treating one eye and you are using other eye as a control. There was rebound increase in axial length, and of course the side effect of axial atropine, like near vision blurring, pupil dilatation, and stuff like that. So they followed up with ATOM-2, where they studied the lower concentration of atropine, particularly 0.5, 0.1, and 0.01. That has been used in both the eyes for at least 2 years. And they found that there is a dose dependent relationship. That means higher the concentration of atropine, greater is the myopia control. But they showed that the follow-up study showed that the rebound effect was minimal with 0.01% atropine. So they concluded that at 0.01 atropine reduces myopia over by 50% over the period of 3 years with the minimal rebound increase and minimal side effects in terms of pupil dilatation and accommodation loss. The next study, which is still currently going in the third phase, is the LAMP study, low dose atropine for myopia progression. It's again a randomized double mass placebo controlled trial to determine the efficacy of 3 different concentration of atropine, where they used 0.05, 0.025, and 0.01% and compared with the placebo. So they found that at the end of 1 year, 0.05 concentration showed the best efficacy in slowing down the myopia. In the third year, as contrast to ATOM-1 and ATOM-2, where they gave atropine for 2 years in this study, after 2 years in this particular study, in one group they continued the atropine, while in the other group they discontinued the atropine, and they found that in the group where they continued the atropine, irrespective of its concentration, the results were better, the progression was less as compared to the group where the discontinuation was done after the 2 years. Right, so this is just to summarize the 3 major landmark trials as far as atropine is concerned. So what we learned from ATOM-1 versus ATOM-1 is that atropine works, but also there is a rebound. ATOM-2 told us that atropine in no concentration is a better idea as compared to atropine 1%. But LAMP is the study probably who is doing a randomized control trial along with a placebo group. It is showing us that 0.05% may have an edge over 0.01%, but we are still not sure about the long-term results. So this is an Indian study which was done from our center. It was a multi-centric study. Multiple centers all across India were involved in this study. And it was a randomized placebo controlled double blinded study again with 100 children, where we found that the mean change of spherical equivalent in the atropine group was less as compared to the placebo group. Similarly, the mean change in axial length was also less, although not very significant, but less as compared to the placebo group. And no progression was seen in around 64%, while some progression was seen in around 13%, and a rapid progression was not seen in the atropine group as compared to the placebo group. So the idea is to know whom do we give atropine. Should it be freely given to all myopic patients irrespective of the etiology, irrespective of cause, irrespective of their pathogenesis? So the idea is that it is basically used for a school myopia. That means myopia which occurs due to constant near work on school going children from age 6 to 14 years, in whom there is a clear cut documentation of myopia progression of more than 0.5 diopter per year, or if there is a spherical refractive error which is within -1 to -6 diopters. So let's be clear, it's not very effective, or I will say it has not been studied in high myopia cases. So anything more than 6 diopter, it is not yet, we don't know the results, even though people may give it and will know, it's used clinically, but we are still not sure whether it works in those cases or not. In astigmatism, if it's less than 1.5 diopter, in anisometropia, if it's again -1 diopter. So the best corrected visual acuity has to be good. There should be no amblyopia. That is the idea. Otherwise, first one will have to treat amblyopia and then treat myopia. So what is the thing that you need to know before you start atropine? When did the child first need glasses? How frequent is the change of glasses? That means how frequently his myopia is progressing. Is there any eye-related issues? What is the child's lifestyle regarding particularly about reading, outdoor activities? Is there any parental history of myopia? Has the child taken any myopia control treatment previously? Is he or she allergic to atropine? And of course, child's basic history about his brief work or visual environment. So we start with basic ocular examination, which is the basic of all the ocular disease. But what is more important is cycloplegic refraction, which should be performed under either hometropine or atropine or cyclopentolate age appropriately. You can do autorefractometry or you can do manual retinoscopy. You can have to do both objective and subjective refraction. The main evaluation includes, which has to be done at baseline, is axial length measurement, amplitude of accommodation measurement, and pupillometry. Then we advise the full glasses correction, full refractive correction, and atropine at night for 2 weeks initially. After 2 weeks, the idea is to look at any side effects. However, there are certain conditions where atropine is contraindicated, like Downs, if there is any congenital or heart disease, if there is cerebral palsy, if there is history of asthma, or if there is use of any other medication. In these cases, you may better avoid atropine. So the first visit at 2 weeks is just to understand whether the patient is having any side effects or not. The second visit at 2 months is to record the change in any visual acuity, if at all there is, or change in the amplitude of accommodation. It's the 6-month visit which is more important, and she will tell us if there is any progression or not. At this time, you have to repeat the refraction, repeat the axial length, and repeat measure the accommodation. So the treatment efficacy of atropine is judged by whether the myopia is progressed or not. That means more than 0.5 diopter change, axial length has elongated over a period of time or not. And you also need to note the other ocular parameters like change in anterior chamber depth, keratometry, and lens thickness. How long do we give atropine? The ideal recommended by WHO is for 2 years. However, multiple studies have given it for 3 years and 5 years, but the recommendation is for 2 years. The patient needs to be closely followed up for the rebound effect once the atropine has been stopped, and also closely monitored for the natural progression of myopia. There will be certain 10 to 20% of patients who will be absolutely non-responding whatever you may do. Or there may be rapid progressors. That means in spite of your treatment, the progression is more than one diopter. The characteristic includes when there is a history of both parents being myopic, if the patient has had his first refractive correction at a very young age, and if the baseline myopia is very high. In these cases, you may have to think about the alternative therapy or the combination therapy or the higher dose of atropine. Many people are now shifting to 0.05% of atropine in these non-responding cases. But yes, we are still awaiting for the results in such cases. The other therapies would be taken subsequently through the course. There are other drugs, other anti-muscarinic drugs, which are still, under the research. There's no data to suggest the clinically efficacy, and most of them have been worked in animal models. The other basic concept of pharmacological management of myopia was to decrease the IOP, because sometimes they used to feel that the increase in IOP is what is causing the elongation in axial length, as we do see in congenital myopia. So that's one mechanism of pathogenesis. So that is also considered, but studies have shown that lowering IOP is not so effective measure to control the axial length elongation. Then the latest drug methylxanthine is also used, but is still under research. Dopamine agonists people are working on it and will have the results soon. There are other anti-myopic agents. I'll not go into details. So to conclude that there is increasing trend of myopia and we are facing it. So let's face it. We should understand what are the modifiable risk factors and devise preventive strategies, which is much more important than providing atropine. There are still lack of clinical guidelines for the use of atropine yet, but yes, myopia consensus statement have been published by AIOS, and we now have some consensus on the use of atropine as a pharmacological agent to halt the progression of myopia. The parents have to be made aware of the risk benefit of the use of atropine. And there's still unanswered question like, if atropine doesn't work, what is the next option? And how long are we supposed to give these options to the patient so that, after some point we can say that it's safe, we can stop here. With that, thank you.
Thank you, ma'am, for comprehensively covering the pharmacological interventions. So I would just like to point out that Indian children as such are low progressing cohort. So while you see a progression of minus 0.8 diopters a year in Southeast Asian children, our Indian children will show a progression of around minus 0.3. So that we need to understand. That's why when the LAMP says that 0.05% is the best concentration, it definitely suits the population. But what we saw in our population, based on the IATOM study, we found that 0.01% gives us very good results. Now, if there is a non-response or poor response with 0.01%, then you should try shifting to higher concentrations of atropine. And another catch is that 0.01% is commercially available. So it's very affordable and easily available to the patient, and 0.05% is not available. So you need to reconstitute it. So only in case of non-response or poor response, we consider shifting to higher concentration atropine. And of course, the mechanism of action of atropine, they believe that somewhere it's acting in the muscarinic receptors in the posterior ocular structures, maybe in the retina, sclera, RPO choroid, which in turn affects the scleral remodeling. So another just etiopathogenesis that Dr. Siddharth was discussing is the peripheral retinal defocus. So at 30 to 40 degrees in the peripheral retina, if there is a hyperopic defocus, then that's a stimulus for axial elongation. So that is why, these days peripheral refraction is being done for research purposes, where you are checking for the refraction at 30 to 40 degrees from the fovea using the peripheral autorefractometer. And based on this mechanism, we have these glasses or optical interventions with the peripheral ad. So now I would like to invite Dr. Murli for his talk on the optical interventions and lifestyle modifications in myopia. And Dr. Murli is a well-known pediatric ophthalmologist from Shankara Eye Hospital, Bangalore. Sir, over to you. Sir, if you would join us on the stage, Dr. Rohit.
I've selected it, yeah, Kaushik.
Can we have the next talk on the screen, please? Meantime, if you have any questions, okay, it's started. So maybe we can discuss the question at the end of the session.
Sure. So thank you so much, ma'am, for having me as a part of this IC. Good to see the hall filling up. I think Dr. Siddharth was brave to go first. He almost was like a radio jockey with just the camera in front of him. But yeah, we've looked at drugs, we've looked at certain other aspects, and it's important to also consider varied options that are available, and not there's not just one size that fits all. At this point, I would like to acknowledge my colleagues at the hospital and our School of Optometry who've been working on some of the work that I would be presenting here today. So like ma'am mentioned, we have two guidelines to go by today. One, of course, is our own AIOS consensus guideline on prevention and management of childhood myopia. And recently, the WSPOS has also come up with a consensus statement. And these two kind of give us some method to the madness in understanding what options are available. They're not exhaustive, they're not comprehensive, and they're not very conclusive either. So you can't just go blindly by them, but they're a good start point for most of us. So we heard about atropine, but then is atropine really a magic bullet? It is extremely time consuming to tell a parent that your child has to use a medicine. We honestly don't know what will happen after 50, 60 years. We've been using it for about 10, 12 years. It's very, very safe. And how sure are we that patients actually are compliant to treatment? So here you're dependent on a child actually reminding the parent to put a drop into their eye before they go to sleep, or sometimes even use a higher dose of atropine where they may have their near work affected. And although ma'am did mention that 0.01% is commercially available, it is not available everywhere. So quite often you will prescribe a medicine and after 2 months they'll say the medicine ran out and sorry, I stopped using it after that. So these do come as challenges, and that's where environment as well as certain lifestyle changes come into play. Now, when we talk of environment as doctors, we're very good at advising people what to do, but often we forget to look inward. So the first step is to look at the environment of our own clinic. So when you look at it, we did a little thing, looked at varied refraction lanes across some of our hospitals across the country. So we had actually compressed our optometry lanes from 10 feet to 8 feet for lack of space. We thought it would be more optimal. And what we've also realized is 8 feet are what most common clinics are. But if you look at what is the accommodation you're inducing, with a 8 feet room, you're inducing almost about 0.41 diopters. Now we thought probably it's just theoretical, it doesn't make a difference. So we did a little quick kind of a dipstick using an open field AR at three distances. And you suddenly realize that yes, even with the open field area, you're able to record it. So what the table on top shows is the mathematical calculation. So if you're using a shorter room, first of all, are you overcorrecting the child and therefore artificially creating a myopia progression? So can you slow down progression by just compensating for the distance is the first starting point. So I think that's something that every one of us can start doing from even tomorrow. The second thing we looked at was the eye level. So most of our pediatric optometry lanes have the vision chart at a much lower level. So does that really make a difference? We didn't find too much of a difference with it. So it's almost like it marginally reduces when you're looking at something that is at about 45 degrees to the eye, and it's very rare to get a child because invariably they're sitting on their parents lap, so that kind of an angulation does not really happen. When we talk of environment or lifestyle, again you're looking at near work, age, schooling, time spent outdoors, and lifestyle factors. So all of these have been kind of blamed. In terms of education level, it's again thought that accommodation plays a larger role, and this can result in multiple things that kind of triggers a stimulus and makes the eye to grow longer. Again, there are studies to show that the exposure to the life at school rather than the age at which the child enters school or the age is more critical. And interventions therefore need to be at a school going age, much younger, rather than wait for the problem to surface. Then, of course, today we are in the era of NEET, JEE, and multiple other competitive exams. Studies from across the world. There is not too much of data from India. We fortunately don't have too many cram schools, but yes, there are a few networks. It would be interesting to look at that. Where children who are in predominantly academic oriented schools spending long hours, children who spend a lot of time doing near work with prolonged, when near work includes computer usage, smartphone usage, and reading, all of these children kind of showed almost like a dioptric increase equivalent to the number of hours. Now, in today's world, it is impossible for you to tell a child not to use a handheld device or not to do near work. So we again looked at it saying that does brightness of the screen make a difference? Brightness definitely makes the person kind of push the screen away. One of the theory that our optometrists have is that when somebody is holding an object close, there's a pull-in effect that kind of makes the eye converge more, and therefore there also is some amount of accommodation. And this has been a theory propounded. So a lot of the work that happens actually looks at relaxing accommodation. So by just increasing the brightness of the screen, increasing the font size, there can be a lifestyle modification where you kind of arrive at a compromise saying that, okay, if you have to do near work, at least do this. Light has been proven again from across the world, higher light intensities. We don't know how it works uh, because we don't know whether it's a difference in topography, whether it's just the green nature that is there. Again, that is supposed to play a role in the sympathetic parasympathetic balance. Uh, could that trigger a dopamine release? We really honestly don't know. But today, schools in Singapore are mandated to spend a significant amount of time outdoors. Unfortunately, with COVID being blamed even today, a lot of schools have cancelled their PT periods or their play periods and have tried to compensate it with classrooms. So those of you who have an influence, please do encourage schools in your area to encourage outdoor time. Uh, Outdoor time again, like I mentioned, in a large cohort, they found that about 40 minutes of play showed a lower development of myopia. Uh, Brightness again seems to play a role play. Most of our classrooms are very dimly lit. Again, we don't have any data from India currently on it in terms of the ambient light in the room that can help it. Seasonal changes have been shown. Again, this is probably attributed to the sunlight exposure largely, and that could result in a thing. We played around with light to see that can we actually make any difference in terms of the accommodation. So we use colored light. So there was a theory that red light can actually relax accommodation. But what we surprisingly found is that even ambient green and red light actually relaxes accommodation, but we've not found it to be significant enough. It didn't cause too much of a problem to our students who were trying to read in that light. But yes, there is a challenge in terms of the contrast. Things don't look the same as a black and white thing. Uh, we again did a small study where we looked at children who spend more than 2 hours outdoors, and we found that even in those who had a family history, they showed a much slower progression with myopia. So today, as a routine practice, we encourage children to spend at least 1.5 hours every day outdoors in sunlight, and we kind of explain to the parent that outdoor doesn't mean you stand in the balcony, but you have to be either on a terrace or outdoors, where we think that it's the interplay of both the light as well as the peripheral stimulation into the retina that probably plays a role. COVID again reiterated this, where again studies have shown that there was a significant progression. There has been a study that looked at housing type, where they found that those people living in the lower floor or on a flat kind of a thing, they seem to progress a little bit faster. Again, probably with single houses, if you're staying on the top floor, the exposure to light is that much more. Obesity, physical activity again have been attributed. Again, is it a direct condition or not? Nobody knows. Uh, we also looked at vitamin D levels. Again, this is something that works. We found almost about 90% of our children are deficient in vitamin D, even those who are outdoor sports persons. Correcting vitamin D3 levels again seem to have some kind of a play in moderating the myopia progression. Now, coming to the optical part, should you undercorrect? So, again, this has been done to death. Undercorrection, we know for a fact, causes education delays, and it would lead to the child being bullied or ostracized. And there is very little evidence to show that undercorrection actually works. So it makes sense for us to give an appropriate cycloplegic correction. Again, how do you know the child is cycloplegic? Give them a reading chart, ask them to read a book. If they cannot read, only then take them up. Because typically our staff are taught to just put a torch into the eye. They look at dilation, not so much at the cycloplegic effect. Uh, do plus lenses work? Again, we did this little thing where we tried giving a bifocal and asking them. But what you will suddenly notice is that the way they're holding the chart, the child will never look through the near ad, but they will kind of bend their head and start peeking from the top of it. So with plus lenses, it's almost impossible to train a child to read. Only the children who are pseudophakic would probably do that. Multifocal glasses have been shown to work, but again, honestly, I've not seen it work with any of the children that we've used earlier. Peripheral hyperopic defocus, we've been speaking about it. So the earliest intervention was looking at orthokeratology, which again has been shown to slow down control, but the recent studies with ortho-K again show it as a combination therapy along with probably low-dose atropine, and that probably will work better. There are a few varieties of ortho-K lenses. Not all of them are equally effective, so it's good for you to understand what would work best and then look at that part of it. The DIMS lenses, again, there are 3 companies that have it. I don't have any financial interest in it. You have the Hoya, you have the SLR, and you have the Zeiss lenses. Each one of it works on a slightly different way. What differs largely is the clear zone that is there. Both the Hoya and the SLR lenses have about 9 mm that is clear in the center. The Zeiss lens has about 7 millimeters, so they claim that it is that much more efficacious. The DIMS lens has certain eyelets that kind of slow it down. Again, this has been proven to work in multiple geographies. It was made available in India more recently. We don't have too much of experience in terms of it, but yes, we do have some amount of children. The first concern we had was, would children be happy with it? Would they be uncomfortable? So when you look at it, you see some reflexes. When in clinic we found that the children were quite okay. And this is the child wearing it on the first day. She's doing her homework, she's doing her near activity, she's running around in the playgroup. So they adapt really, really, really fast. And this experience, I'm told, talking to some of the trade, is seen with all the 3 lenses equally. We again had some personal communication with the Hoya folks, trying to understand. We don't know the progression data from across India, but as a surrogate, they have this exchange offer where they say that all the companies today have it, that if the myopia progresses by more than 0.5, they would replace it free of cost. So we asked them, how many returns have you got? Fortunately, these lenses appear to work because in about a year's time, they've not had too many of it being taken back. The halt lenses of SLR again work on a hexagonal kind of a defocus zone. So we do have multiple options available today, and it is good for you to play around with it. In terms of lifestyle, encouraging children to spend time outdoors is a no-brainer. Getting the vitamin D levels tested every 6 months is probably 2 things that we could very immediately start off. Talking to schools to encourage outdoor play is important. Optical, what seems to work fastest are the DIMS lenses. Do you use it by itself? Do you use it in association with atropine? Because of the cost today, we are only able to encourage parents who are not responding very well with atropine to actually start using it, and that probably is what we would be doing. So thank you.
Thank you, sir, for beautifully demonstrating the optical intervention, especially, you see that the usability is less in India. So sir has demonstrated beautifully with the videos and what all clinically you can face the difficulties while you're prescribing it in a child. Can we go on to the next presentation? Dr.REBIKA. So I'm Dr.REBIKA. I'm a faculty at API Center, AIMS. And with Dr. Rohit, Dr. Swati as our pediatric ophthalmology unit is working on myopia. We have a myopia research team which is doing a good job, and hopefully we should come up with more research papers, just like IATM was a multicentric trial. So now, after having heard about the various evidence-based interventions that we have, now let's move on from preaching to practice, that how you should apply it clinically in your day-to-day practice. So before we jump onto that, just understand what myopia is. So definition we all know, but we must not forget, do we have a pointer? So we must not forget that what is important is that in myopia, when you are taking the refraction, accommodation should be relaxed to avoid the misclassification of myopia. So first do a cycloplegic refraction and then label the child as myopia. Then another important terminology that is being introduced is pre-myopia. So pre-myopia is a recent concept, which even IMI white papers are discussing it a lot. So what is this state? It is a state where the child has a lower baseline hyperopic refractive error as compared to their age normal children. And they also have other risk factors for myopia. So the advantage of identifying these children is that you can, because they are at a greater likelihood of future development of myopia, you can identify them and probably start preventive interventions like lifestyle modifications in them. So that's why pre-myopia becomes important. And in fact, ATOM-3 is a trial that has been taken up by the Singapore SNEC group, where they are trying the usability of atropine in pre-myopes, but it is not established. So for now, pre-myopes is just for identification and preventive interventions. So what is the burden of myopia? Well, globally, the prevalence is around 23%. And according to the Bryan and Holden group, the prevalence is expected to rise to as high as 50% of the world's population by 2050. So this is a study that actually created a lot of buzz. And based on this, if you see the problem is so staggering, especially in Southeast Asia, prevalence almost 80 to 90% in young adults. Look at the Indian scenario. So percentage-wise, if you see, it is just 7.5%. It is just 7.5%. But if you look at the humongous population, especially of the young children in our country, the numbers could actually be very staggering. And also the trend has been rising. Near doubling of prevalence has been noted in a recent meta-analysis that we did in the last 4 decades. We realized that there is near doubling of this prevalence in the 11 to 15 years age of children, not only urban, but also rural. So that means whatever was the modifiable risk factors, probably whatever was acting, has also penetrated into the rural environment. So what is the impact of this disease? Well, clinically, it is a leading cause of visual impairment worldwide because of the associated retinal complications. That's why they are saying that even if you're able to save 1 diopter in a child's life by these interventions, you can actually prevent 40% of these complications. Psychological impact, the children wearing those myopic glasses, they can have low self-esteem, poor quality of life. Economic losses are also predicted, amounting to billions of USD per year, and Asia being the worst affected. So now coming to the practical part. A child walks into your clinic with a myopia. How do you manage it? So first important thing would be a history. So history is important because through history you will get the idea about the various risk factors that the child has. So that would include the age, the gender. Take a history of general ocular and general health of the patient. Parental history of myopia, whether single parent, both the parents, what is the amount of refractive error, and what was the age of onset in the parents. The siblings, ideally you should screen the siblings as well. Then child's visual environment should also be screened. Like what is the amount of time that the child spends outdoors, the time spent on near work, then the digital screen duration and the type of digital screen used and lighting conditions at home. So this history is important. Then if the child is already using myopic glasses, then you should also assess that what was the age of onset of myopia in the childhood, age of onset of myopia in the child, was the baseline refractive error of the child, is there any history of progression in the past few years, and whether the child has used any previous myopia control interventions. So once then after the history, you should come on to the investigation. So we did this consensus guidelines that sir was talking about. So we have recently, it is being accepted in IGO, so will be very soon published and will be available to you. So we have divided these interventions into 3 parts. So must do should be vision. You must assess the IOP, anterior segment, posterior segment, and the cycloplegic refraction. So cycloplegic refraction, 1% cyclopentolate, 2% homatropine, or even 1% tropicamide. But just remember that you should take the refraction or do the refraction within 30 to 45 minutes of prescribing the drops. And then good to do other important things, ocular biometry. Because ocular biometry will help you assess that how much the child is progressing with or without treatment. So do the refraction of the child, axial length of the child. Then other interventions or other investigations are optional or for exploratory or research purposes, like corneal, like tear film assessment, binocular vision assessment, peripheral refraction that we were just discussing, pupillometry, etc. So then based on this, you can divide what are the risk factors in the child, modifiable and the non-modifiable risk factors. And do you do a risk factor stratification for the child? Then the next question is whom to treat. Do every child with myopia needs to be treated? The answer is no. So, if the number of risk factors are greater, then there is a greater chance of progression of myopia. And also remember that while these risk factors can predict the progression, but it cannot exactly tell you how much the child will progress. So, we just get a rough idea that this child might progress. So, in a child, if there is no evidence of progression, there are minimal risk factors, it is always a good idea to observe that child and follow up, maybe on a 6 monthly or a yearly basis. And the most accepted intervention for starting any anti-myopia therapy would be progression of myopic refractive error more than 0.5 diopters a year. Apart from this, presence of some risk factors, high risk factors like young age of onset, parental history of myopia, and other risk factors that we discussed. So this is where you should decide whether to treat or not to treat. Pre-myopes, as I just pointed out before, that in pre-myopes, it's important that you identify these children, keep them on regular follow-up. Advise the parent to start the lifestyle and environmental modifications so that the myopia in them, they do not progress on to become myopic or high myopes. Available interventions, Dr. Swati and Dr. Murli have already discussed. So amongst these available interventions, so I'll just discuss the practical aspect of it. So spectacles, two types of mechanisms have been described. One that reduce the accommodation lag. So for this bifocals, the most effective that have been found is prismatic bifocals, and commercially available ones are your Myopilux, Myopilux Lite, and the Essilor. So Essilor has this Myopilux range of lenses, and Zeiss also has MyoKids, but they have not been found to be very effective other than the Myopilux Max. Then based on reduction of accommodation, so based on the reduction of peripheral hyperopic defocus. Now these lenses are myopia specific lenses which have been designed specifically for myopia, and they have shown better efficacy, and they are all commercially available now in India. So Hoa MioSmart lenses, Essilor Stellest, Zeiss MyoVision Pro, so most of them are available. But look at these, the disadvantages. It is the cost. 16,000 a pair, maybe one change is allowed if the refraction changes within 6 months, but it's costing 6,000 a year to the patient, and efficacy is less as compared to other interventions. But advantages, it's least invasive, corrects as well as controls myopia. So it's a dual therapy. It is correcting for the myopic refraction and also controlling the progression. And it is simple to use, easy to fit, and well tolerated and accepted. But as Sir was saying, that there could be practical implications, like the child may not be seeing through the but if you're using these peripheral hyperopic defocus glasses, here the chance that the child looking up through the near-ad part of the lenses will not be there. So these lenses are probably more effective that way. Then orthokeratology, well, minimum 8 hours of wear is recommended, but remember it is effective only up to 4 diopters of myopia. For myopia more than that, you will have to prescribe glasses even for the daytime use. So the advantage that have been the only advantage with ortho is that eliminates the need for daytime correction. But the disadvantages, it is a high risk of keratitis. There is shortage of trained practitioners. So most of the time you will not find optometrists who are able to fit these lenses. There's low acceptance, and of course the use is off-label. Even the studies that have been done on OK, they have shown that there's a high dropout rate. And the only lens that has received CE marking in Europe for myopia control is Menicon Bloom. Then soft multifocal contact lenses, again here we have a range of these lenses, and what is available is your SEED one-day pure EDOF lenses are available in India. MeSight and Natural View are yet not available in India, but look at the cost. It is a costly affair for the patient, and much more than the spectacles. And finally, coming on to the low-dose atropine, well, the advantages is easy availability, administration, affordability, minimal side effects. But we cannot ignore certain disadvantages that only 0.01% has received the CDSCO approval. The use of other concentrations is still off-label. So remember, if you're using other higher concentrations, you need an informed consent from the parents. Then rebound phenomena has been noted with higher concentrations. So do not just stop it. You must taper the drop before stopping it. And exact mechanism of action unknown, and there are a lot of unaddressed questions like what should be the ideal dose and duration. So once you have decided what therapy you want to start in a child, Ideally, it should be done in consultation with the parents and the patients. Give them an informed choice. First, inform them what could be the potential risk that if you are allow the myopia to progress. Then explain what are the various risk factors that has led to this and what changes could be brought about in the child's lifestyle to avoid the further risk. And and give an informed choice to them, start the treatment, and keep them on periodic follow up. So remember, informed consent is important if the use of any of the interventions is off label. Follow up schedule. So this is the follow up schedule. If it's low dose atropine and bifocal or spectacles, follow up is needed, maybe one follow up at 1 month and thereafter 6 monthly. But if you are giving contact lenses, then you need much more frequent follow up. And remember, the review schedule can be individualized based on the patient's symptoms. So these are the follow-up investigations. So baseline investigations we discussed. So on follow-up, what all you should do? So at 3 months, ideally, you should repeat the cycloplegic refraction, check the ocular health of the patient so that there is no change in ocular health related to your intervention like eye drops or optical interventions. 6 monthly, repeat the biometry for any progression, and annually, you should do a dilated fundus examination as well. It is always a good idea to maintain this myopia growth curve, because this growth curve gives you a very nice idea that what was the growth curve before the treatment. And in this is an example of our patient, that how it attenuated after the treatment, and then how after stopping the atropine, again the rebound was seen. So this growth curve becomes important. And finally, all this I think has been discussed by Dr. Swati, that how do you analyze the efficacy on follow-up in terms of the spherical equivalent progression and axial length elongation. So these are two primary outcome measures. And treatment duration, well, no consensus. Ideally, you should continue treating as long as the myopia progresses. But most of these interventions have been assessed for a period of maybe 2 or maximum 5 years. So decide on a case-to-case basis. It is all clinicians' it will depend on the clinician's management protocol, and close follow-up is recommended, especially if you're stopping the treatment, to look for any rebound effect. Responders, non-responders will be there. Despite your best possible intervention, there will be some percentage of patients who might not respond. So in that case, step up your therapy. You can go for higher concentrations atropine or go for combination therapy. So maybe atropine combined with the lifestyle modifications, or maybe combined with optical interventions. When should you ideally change the treatment? When your interventions are not working or there is some side effect related to this therapy. But just remember that all these anti-myopia interventions will slow the progression. They cannot stop the progression completely. So this you need to explain to the parents. But as I told you, each diopter matters. Even if you're able to save one diopter in the child's life, progression of one diopter, it will reduce a lot of risk of retinal complications. And of course, at the end, I would just say public health initiatives are equally important, because prevention, which is the most important mode of myopia control, that is possible only through education, not only in the general public, but also amongst the teachers, who probably may be the first person to notice that the child is having some visual issues. Then we need collaborative research amongst ophthalmologists, optometrists, and school interventions. We need school reforms. At the school policy may need proper reform, just like it has been done in Taiwan and China, where they have made outdoor activities compulsory, and they have reduced the exhaustive school curriculum and homework for the child. So, and with this, I would like to conclude. And rest of the unanswered questions would be taken up by Dr. Rohit, because there are a lot of unanswered questions still in myopia, a lot of clinical dilemmas. So, sir is our professor. He's the head of strabismus, neuro-ophthalmology, and myopia services at our center, and the sheet anchor of the myopia research at our center.
Thank you, Rebecca, for the opportunity and, of course, devising this wonderful course. So she gave me to talk on unanswered questions. Now, I mean, assuming as if I knew answers to the unanswered questions, then I'm sure they would not have been listed as unanswered. But anyway, please, the slide if possible, please. Yes, Rohit. The one that is highlighted. Yes, great. So, thank you. So, a lot of unanswered questions, and frankly, I don't think we still have the answers to them. So I'm just kind of throwing them, and I'll give you some of the ideas which we have, or what the collective wisdom at the moment in literature is there. And of course, I'll be open to opinions and updates and information from everybody here, knowing that now everybody has to practice management of myopia in children, just like cataract. I think the next most important thing that we'll be dealing with as time goes on is myopia. So all of us need to be aware about it, and all of us would have their own different ways in managing it, just like all of us have different techniques in cataract. So similarly, all of us would have our experiences in managing myopia in a child, because that's what we are gaining and our understanding is going. So first thing, why does it occur? Now, there is a very clear evidence that it is changes due to lifestyle. In fact, now last few months, I've actually stuck my neck out, and I'm going everywhere aware, and I believe this strongly, that myopia in children is the youngest lifestyle disease in humans. Over the last 30 to 40 years, across genetic makeup, across races, the magnitude of myopia has significantly increased. And obviously, genes don't change in 40 years. It's clearly the environment or the environmental influences on the genetic makeup that has made this happen. In fact, there is a very interesting study from Singapore which showed that the first generation immigrants from India to Singapore had about the myopia prevalence of 12 to 14%. And the second generation, their children there, it jumped to about 24 to 28%, showing the impact of environment on the same pool of genes. So there is no doubt that whether individually or in association with a lot of other factors, some of which was discussed, like vitamin D, our behaviors, stress. So all these things, how much they have, but lifestyle definitely has a change. As I mentioned, some genetic groups are more susceptible, whether it is because they have incorporated the environment much earlier. We know that Asian children are very, very pressed to be high performers. So is it because of that very, very stressful environment they are in from the very beginning? And that has been seen in the last 40-50 years, particularly in the East Asia part of the world. Although I don't think India was bereft of this, but thankfully we still have a lower percentage of myopic children. But there could be that some genetic races are more susceptible as compared to others, but all of us, irrespective of race, are affected. So I talked about the Singapore study. So again, back to, definitely environment has a huge role to play. We are still understanding the role of light, nutrition, like I said, the stress levels, or whatever we are eating or breathing. So we are not sure what all makes a difference, but definitely environment, and particularly we've talked about the distances of reading, our lack of going outdoors. All these are major factors that are changing, and that's where all the research is going on. As I mentioned, I think youngest lifestyle disease in humans is myopia. The next question comes, how does atropine work? That's been on the back of our minds for a long time. And I really understood the word serendipity with the vaccines, when they told us how they actually stumbled upon the dose of vaccine for COVID. But really, it was serendipity that we came to low dose atropine. 0.01 was actually the placebo in the ATOM study. The basic concept going in pharmacological therapy is that if you 100 times dilute what is a known effective dose, you can use that as a placebo instead of a vehicle. So they thought that 1% works. So 0.01%, 100 times the dilution, is an ideal placebo. And serendipity, they came out that low dose atropine, or 0.01, was very good. I won't say the best. If you read the study and if you read all the literature that is available, and you kind of crystallize it or distill it into understanding, atropine has a dose dependent effect on progression of myopia. Why we like low dose atropine? Because of its minimal or negligible side effects, as also the rebound that they realized was more higher the dose. So finally, when you stopped it, the most effective drug or most effective concentration was 0.01. This could, as Dr. Rebecca was talking about, this may be different in different races. There is an ongoing trial in India on 0.01 versus 0.05, and let's see how the efficacy of 0.05 is. We expect it to be better, but obviously we know that the side effects are more. So maybe every race will have to come out with its preferred concentration levels, and till the time we are able to understand that, each decision or concentration on a child has to be an individual based understanding or information. So at the moment there is clear lack of evidence how it works. There is a lot of concept that it works by acting on the posterior segment, on the retina, on the choroid. This was a question that actually hounded me, and this was something we thought that actually I wanted to disprove. I thought it can't, 0.01 can't reach the vitreous. So why are we saying that it's going to affect the retina, choroid, sclera, and maybe the cortex also? So we did this study. It was an interesting study, and hopefully we'll get it published soon. We did 1 drop of low dose atropine and got vitreous and aqueous samples, very ethically, of course, prior to cataract surgery. 1 drop of low dose atropine, and an hour later, when we did the cataract surgery, we did the aqueous tap. And similarly, before vitreous surgery, an hour, 2 hours, 6 hours, when just before doing vitreous surgery, of course, for some other indication, cataract surgery for a patient with cataract, vitreous surgery for a vitreous hemorrhage or something. Not the ideal environment, but we were able to get measurable levels of atropine in the aqueous and vitreous within 1 hour of the drop. So it reaches where we are saying it is supposed to work. Now again, the fact that it reaches the vitreous does not prove that it works in the posterior segment. But as I said, that was an interesting thing that we actually have observed. So probably it is acting on the posterior segment. But we also find clear evidence that it works in the anterior segment, and that is a no-brainer. Atropine is a cycloplegic. Whatever the dose level, its primary aim is to cause cycloplegia, and it definitely does that even in the low dose levels of 0.01. Again, another publication we actually hopefully will again come in sprint soon. We evaluated the change in the lens power by doing progressive biometries in these children who were on low dose atropine pre and after their treatment, and we found a significant measurable change in the lens power on atropine. So there's always been that, you know, the criticizers of atropine have always said that why is there this disconnect between the effect on refractive error versus its effect on axial length? Why is there no good correlation between the two? So one of the possible answers, and everybody speculates, that is possibly the anterior segment change. So atropine must be working, there is no doubt about it. But low dose atropine or any dose of atropine partially works by causing cycloplegia also. And maybe that is why the rebound, when you stop it, obviously the power comes back, and what you call as rebound is probably recovery of the accommodational tonus of the ciliary body, and therefore it works, but not as great as we think it does. Again, these are, as I said, this is all under the discussion of unanswered questions. I'm not saying that anybody asked here has the answers, but possibly. So this is the question: why the disconnect among low dose atropine, possibly the anterior segment changes, loss in the crystalline lens power, and as I mentioned, possible cause of some rebound. Is peripheral refraction mandatory workup in myopia now? When we are talking that the concept of these spectacles is peripheral hyperopia, and our lenses are designed to prevent or overcome that by creating mid-peripheral myopia, is this necessary now? At the moment, there is no evidence that you need to have peripheral hyperopia for these spectacle lenses to be effective. So at the moment, all types of refractive errors have been found to be manageable or managed by these lenses. The Hoya, the SLR studies have not shown any difference in the result with relationship to peripheral refractive errors. And therefore, at the moment, I would say it is not an essential component. It does not decide the way you're going to manage or what you're going to do. So there is no evidence that spectacles with peripheral add are helpful only or significantly in children with peripheral hyperopic. And what do we do with if the child is still progressing on treatment? Again, most important workup for treating myopic progression is baseline or the amount or magnitude of refractive error change prior to your intervention. You must know how much the child is progressing before you start treating what you have to treat what you identify as disorder. Just because a child has come to me with refractive error and has a moderate myopia and I do not know how it was 1 year ago is not the indication of starting treatment for preventing myopia progression. The child has myopia today, you have to prove he has progressive myopia and then start treatment. So you must know the rate of baseline refractive error change or rate of myopia progression before you start treatment. It's like, you need to know there is glaucoma before you start giving anti-glaucoma medication. It is must. Because it will tell me whether I am treating effectively or not. If I do not know baseline IOP, how do I know my drug that I have given blindly is working or not? Today the patient's pressure is 24. I don't know it is from 30 or from 25. So the drug I am giving, is it effective or I'm just increasing the side effects? So when I know the rate of baseline myopic progression, I start treatment A. I observe it 6 months. If the rate of myopia progression has reduced, I know it is working. Now, whether it's working satisfactorily or as much as I want is the second part of the question. But the first part, the drug, yes, is working. He was progressing at, say, 1 diopter. Today, he's 0.5 diopters. Now, 0.5 is also high. I supplement because I know the drug is working. But if there is very little effect, he was progressing at 1 and he's changed by 0.75, I may think in terms of substituting. So we know additive therapy of optical and pharmaceutical work. So that is how I'm going to decide. Why treat everything simultaneously in all children? You don't give all the available anti-glaucoma medication to every child, every patient of glaucoma who comes. You choose, you identify the most appropriate therapy, you follow up. So same rules we should use for a long-term chronic 2 years or more therapy. The most important question, when do we stop treatment? If I start anti-glaucoma medication in a younger child, clear evidence, younger the child, the faster the rate of progression, the higher the baseline refractive error, more the child is going to progress. I'm going to continue for 3 to 5 years, which is the evidence of treatment at the moment available, because I know these children have the tendency to progress till 15, 16 years of age. If I pick up a child more than 10 years of age, these are my arbitrary decision tree. It's not based on fact or science, it's based on experience and what I feel should be. So if it's an older child with lower baseline myopia, I may treat for 2 years, stop and look for rebound. Of course, never stop standard, just do a small taper over 6 months and then follow up the child and see. If it rebounds, if you see again a progression, restart. So that's how we have to, have evidence. How to choose what to take, opticals, pharmaceuticals, there is no clear evidence at the moment on anything whatsoever. So I would say the most important thing is factored in is should be economic, whether the parents can afford it, because we can't force them to buy something which we are still finding evidence on. Essentially poor ocular surface, obviously no contact lenses. High myopia, high astigmatism, atropine only because spectacles, contact lenses not available. Child has decreased near vision, accommodative lag. It's important to check that because earlier we used to think myopes won't have accommodative lag, but they do. So in them, be a little wary of starting atropine. And of course, like I said, economic constraints are the most important. We're still not sure red light, blue light, because both have shown to be effective. So I don't know which color light is effective. Role of vitamin D has been discussed. Again, whether it's a confounder because of outdoor activity or there is a kind of role for treating with vitamin D. But, orthopedicians and everybody has told us that 90% of Indians are vitamin D deficient. So it should be a staple diet. So I don't know how much it's true or a confounder. Pre-myop was discussed. I would say that lifestyle changes have shown to have 30 to 40% impact. I would say every child should be encouraged to do lifestyle change, see the impact before you start giving treatment for myopia, because after all, he's a pre-myope. You don't treat pre-glaucoma or glaucoma suspects. So you don't treat pre-myopia, at least in the low prevalence country like India. So it's very, very important that we decide what we are going to do. And finally, questions we don't know answers of. Can we stop myopia progression? We don't know. We cannot stop it completely, but yeah, slow it down. And we still don't know how we are going to answer a lot of questions that we still don't know. Thank you.
Thank you, sir. So I think still we have a lot of dilemmas related to myopia, but a lot of research is coming up day by day. So it's very important to keep yourself abreast with the ongoing research, so that as a clinician you can manage your patient well. So now, since there's a lot of speculation about the digital screen time and its impact on the ocular health and its role in myopia. So, but it's all contradictory, you know. So no, we do not have enough evidence to support it as per the literature. But we still recommend it as a lifestyle modification. So now I will next call upon stage Dr. Sonali Rao for her talk on the impact of screen time on ocular surface in children. So I think this is a very important subject that we all need to discuss, not only for our patients but also for our own children. And Dr. Sonali Rao, this is the Hanumanta Reddy Award. She has received the award for her talk on this. And Dr. Sonali Rao is working at Lions Hospital, a renowned pediatric ophthalmologist in Lions Hospital, Bangalore.
Good afternoon. So after all that myopia talk, I'm going to talk about the impact of screen time on ocular surface in children. So we know that the daily media consumption has increased in today's pediatric age group, and the use of smartphones and tablets is the new normal. And after COVID, the increase used often leads to a variety of asthenopic symptoms. So we know that the pediatric population is more tolerant to these symptoms generally, but many of them go undiagnosed. So there is a strong need for a uniform protocol to screen for dry eye disease irrespective of symptoms. So what did we do? We wanted to evaluate the impact of electronic media use on the ocular surface health in children. So this was a cross-sectional observational study that was done in our OPD between September 2019 to October 2020 in the age group of 5 to 15 years who were using the appropriate spectacle correction. We excluded children with congenital abnormalities of the eye, severe allergy, trauma, or any other pre-existing ocular conditions. So the regular statistical analysis was used. So we included 78 children in our study, and each child, actually the parent, was given a standardized questionnaire to answer. A standard ophthalmic evaluation, slit lamp and fundus examination was done, and we did the dry eye evaluation using the OSDI scoring, Schirmer's test, tear breakup time, and fluorescence staining. So this was a questionnaire that was given to the parent. So we analyzed a total of 78 children, mean age of 11 years. We had 42% females and 57% were males. So coming to the percentage of device use, we can see that 45% of the children, they use smartphone and television, whereas 19% used all three devices, that is smartphone, television and computer, 19% only smartphone, 12% smartphone and computer, and 5% only television. So based on the screen time, we divided the population into study control group and study group. So control group were the children who use less than 1 hour of smartphone, and this was divided into control 1 and control 2. So children who use less than 3 hours of other media were control 1, and more than 3 hours of other media were control 2. Whereas in the study group, if children use less than 3 hours of other media, they were in study 1, more than 3 hours of other media study 2, and more than 4 hours of smartphone were in study 3. So here we have around 41 subjects in study 1, 6 subjects in study 2 and 3, and 4 in control 2 and 21 in control 1. So when we analyzed, we had the percentage of those with symptoms increased as the screen time increased. As you can see here, in the study group 2 and 3, almost 100% of them had symptoms. So the symptoms were headache, tearing, burning sensation, and headache was the most predominant symptom. So then we analyzed the OSDI scoring in all these kids, and OSDI scoring was greater than 12 in almost 57.7% of the population. So you can see here that the OSDI scoring is increasing as the screen time increases with a significant p-value of 0.001%. Then we come to the Shermer's test. So once we analyze the Shermer's test, we realize that as the electronic media use increased, the Shermer's value also decreased with a p-value of 0.06 in the right eye, and it was significant in the left eye with 0.02. So though none of the study population had a Shermer's value of less than 10 seconds, but it showed a decreasing trend as the duration of screen time increased. Next, coming to the tear breakup time. So even in the tear breakup time, we can see that as the electronic media use increased, the tear breakup time decreased. So there was a significant decrease in the T-but across all the groups as the duration of screen time increased, with a significant p-value being 0.001 in both eyes. Next, coming to the fluorescent staining. Fluorescent staining was noted in 7.7% of the population, though it was not clinically significant, but you can see that fluorescent staining was higher in those children who use more screen time. So comparing our study to the other studies in literature, so there are 3 studies. The first was done by Jung Choi. He compared adults. So he compared smartphone versus OSDI score, and he said that smartphone use aggravated the OSDI score. The second study by June Moon et al., they did a study on children. They compared 288 children. They evaluated the electronic media use versus T-but and fluorescent staining, and they said that smartphone is an important dry eye risk factor in children. Another study by Katharina, she also compared 322 children between the age group of 3 and 10 years. They compared smartphone versus visual issues, and she concluded that asthenopic symptoms was higher in the video game group. The only study that contradicts our study was that was by Benjamin, but he had evaluated 344 adults. He compared the commonly used dry eyes like us, like Shermer's test, T-but, OSDI, and fluorescent staining, but he did not find any demonstrable concordance between any of the signs or symptoms. So our study revealed that a significant portion of the study population had symptoms. The OSDI score showed significant increase in those with very high smartphone usage. The T-but also showed a decreasing trend as the screen time increased. While not statistically significant, fluorescent staining was also higher in the group with high media use. So while the results did not indicate a severe disease, OSDI T-but values, they did show a significant change as the duration of screen time increased. So in this generation of ever-increasing dependency on electronic media devices, both the children and parents need to be aware of the ill effects. So study like these compare the direct effects of screen time on ocular surface health become more important. Our drawback of the study was that it was a small size and limited duration of only 1 year. So there is a need for more holistic diagnostic policy that can diagnose dry eye before the apparent symptomatic manifestation. Thank you.
Thank you, Dr. Sonali. Dr. Sonali received the best paper in pediatric ophthalmology for this study of hers. So I think if we have any audience questions, we can go on to that. Yes, please.
Mike. So, myopic astigmatism in children, we know anyway would tend to come down with time. And there is no evidence or no particular reason. So, the effect of atropine is to be on the axial length. And almost always the astigmatism is anterior segment in origin, unless there's a tilted disc or something. But most commonly it is corneal. So, if you have high astigmatism, identify and look for keratoconus or form fructic keratoconus. Follow up the child for that. But up to 3 diopters of astigmatism in a young child up to 3-4 years, 6 years is not very uncommon, provided it's not causing amblyopia. I would just say correct it, refractive error correction, and follow up.
And also, if all these studies have proven the role of atropine only in simple childhood myopia, not for secondary myopias, although it's being used off-label in a lot of other myopia related to ROP, high myopia. Even in high myopia, the role is not proven. But studies are still underway, and maybe in future we'll have the results and some evidence supporting it. But as of now, the evidence just supports its role in simple, mild to moderate childhood myopia.
Yes, ma'am. So peripheral refraction is the refractive error in the mid periphery of the globe. So the basic hypothesis is that which you gave single vision glasses correct for the foveal refractive error, but the retina at the back or the sclera is not an absolute round ball, it's oblate, so there is a change and the peripheral part shows a hyperopic refractive error, and that is the cause for myopic progression. So essentially, theoretically, you can do it by asking the patient to look off axis, get a measured distance, give an angle change, and give a fixing target so that it's about 25 or 30 degrees off center. So the patient is looking off center and you're doing your refraction from straight head on, and you're refracting or neutralizing that part. So that is peripheral refraction. A lot of handy devices have come in, including from LVPI and or the Jethani, which are kind of like, help you to do that give you a correct fixating target so that you can do that retinoscopy or refraction that you're doing. Of course, commercially available open ARs are there. So in a normal AR, you're looking straight and you're supposed to look at the light. These are open ARs which have lights which are at different degrees from the primary axis. So the patient looks there and the machine does the AR at that 25-degree or whatever. So that is peripheral refraction.
So basically, it helps you understand that the peripheral hyperopic defocus, it's happening somewhere around 20, 30 degrees of the retina. So that has been most studied, 20, 30, 40 degrees, and studies have shown that around 30 degrees somewhere the hyperopic defocus is happening. That's probably a stimulus for your myopic growth. So if you find this peripheral defocus, accordingly you can probably go for optical interventions that provide a peripheral add. If the child -3, the child who is already having myopia, and we'll have to look at the risk factors. If as sir discussed, if the risk factors are high, we need to definitely start the therapy in the child. Sorry.
Why it happened?
Oh,
So
why?
so so two children are brilliant, one child is not so. Two children are fair. So there's a huge genetic variation in the refract. So emetropia is not zero refractive error. Emetropization means that the eye should remain at rest for the longest duration of time without spending energy. The moment you look near, the brain is actually expending energy. So that is why we know generation by generation we are becoming myopic, because myopes see near without any trouble. So for the brain, the feedback is that a myopic eye is no work at all. That is why. So some children have a more tendency, depending upon their epigenetic makeup, depending upon their environmental or no, so the genes may be same,
I,
so
I,
even twins are different.
I
Yeah.
think I covered it in my talk. The penetrance of myopia gene is only 5%. So even if you have the gene, you may not manifest myopia in 95% cases. And if you have one parent as myopic, you have only 10% risk of myopia. And if you have both parents myopic, you have a 25 to 40% risk of myopia. So I think that answers the question. I mean, all three may have the gene. In one child, it may manifest. In the other two, it may not manifest. It doesn't mean that they don't have the gene.
Or the risk.
Pardon? Depending on. So if you go through the American Academy of Pediatrics preferred practice patterns on amblyopia.
You mean myopic glasses or myopic glasses?
Myopic glasses. So it is a need-based thing. So if you have a child who is 2 years old and he's -1, you won't prescribe it. If it's a 5-year-old child, he's got -1, you'll prescribe it. So
Also, we need
that's
to document the progression first. Unless you document the progression, it's always a good idea to wait for maybe 3 months or 6 months and look at the change that is happening, as sir was discussing. Get the baseline curve, that how the myopia, how much it's progressing. So once you get the baseline rate of progression, after that you can plan whether some intervention is needed or not. Ideally, I would think that if there is no previous records of the child showing the prescription or anything, and it's a first time contact, wait for the child. First time you're prescribing, then wait for another few months. If there's a progression, look at that rate, how much it's progressed in 6 months or 3 months. And then
What will be the progression you would expect in 3 months?
In 3 months, we will not expect much. But if it is a high myopia rapid progressor, maybe in 3 months also we can see some change. But 6 months, definitely you can see some change. 6 months would be an ideal thing, as you say. 3 months is less, but in rapid progressors, you might even see.
Last, I think.
I've been monitoring Lenstar, and in those patients who in 6 months about 0.1 mm increase in axial length, they generally don't have change in refractive error. Now, is that probably the non-axial length causes you were talking about change in that case? Have you observed that?
So that is one of the possibilities. Yes, there is always that little disconnect. The other thing is there is always that least count that is there. So the measurable distance by different machines and different refractive error measurements, how much we are taking as our least count for difference. So I would say yes, there is a disconnect, and as I said, our thought was that probably it's anterior segment in relation, but the disconnect is only very modest. So if you are again on sequential follow-up seeing and observing axial length change, it obviously is a cause for concern. Why it is not reflecting the refractive error change is something that, like, every child you need to check whether there is an anterior segment change in power or not, lens power or not.
You're monitoring a pre-myopia. What
Yeah.
is your cutoff for calling it progression on the basis of axial? You are monitoring over 6 months or 1 year.
So essentially equivalent to the way we would call progression in myopes. So 0.5 diopter progression is progression, 0.5 change, either reduction in hyperopia or shift towards myopia would be for refractive error. For axial length, 0.3 is usually what we are taking as a significant change.
Over 6 months or over 1 year.
So ideally it should be over 1 year. This is an 1 year calculation that I am saying. So all our studies are measured for 1 year. We are extrapolating it at 6 months because we may be concerned about a rapid progression and may apply it at 6 months. But all progression decisions are essentially based on change over a year.
I'm just answering your first question. The 0.1 mm change is can bring about 0.2 to 0.25 diopters change in the refractive error. So it probably might be missed.
Yeah, exactly. So least count maybe that.
This is just an observation.
Yes.
You mentioned
So-
about those factors.
Yeah, it could be, like I said, that could be possible. It could just be part of variability. Unless it's consistently showing, it may not be, factor. Thank you. I think we'll call it day here.
Yeah, thank you all the speakers. And with this, we end the session. And I hope the speakers for the next session are available. So we hand over the stage to them. Thank you.